contraception, and then in the end part of this, the last section, we're going to go into abortion. We're going to end with some sort of ethical discussions and group sort of thought experiments and shares at the very end. Hopefully we get to it today. And this is going to be really, Dr. Sharon talked all about sort of trying to get pregnant, ways to know that you can assess your fertility, you can be proactive. How do you want to get pregnant? If you do, what are the ways? This is going over how not to get pregnant, right? So we're going to go through some of the standard contraceptive methods that we have, especially in the US, and then we're going to get in the end to this last section. So contraception actually means against conception, right? You were trying to prevent conception. There's lots of different types. We're going to talk about the majority of these, okay? And there's even male hormonal contraceptives. Those are being started, research on them, clinical phases, even here in the US, mostly in Europe, but even here now too. When I was at UW in Seattle, there was already people working on this. And you might think, what? But actually a lot of men are willing to do this. Surveys actually show this.
I better be.
Okay, they better be. Okay. So abstinence, coitus, interruptus, rhythm, oral contraceptive pills, tubal ligation, IUDs, female condoms, male condoms, vasectomy. Those are the ones we're really going to emphasize. We're going to go through those, the pros and the cons. Okay. So what I have to say for all of these, they work in a lot of different ways in both the female body and the male body. So there are a bunch of different events that happen, right? Production of viable eggs, that's a key event to achieve a conception or pregnancy. Production of viable sperm, the one that is able to make it, fertilize, gets transported in all those male ducts we talked about, deposited in the female vagina. Sperm has to move through the reproductive tract, usually out to the ampulla of the fallopian tube. Fertilization happens, early development happens. If the pregnancy is maintained and healthy, it'll go all the way to birth. And we'll look at the numbers of some of these too, how this process dwindles down naturally. But the way contraceptives work is combination methods or progestin-only methods, things like emergency contraception. You guys have heard of Plan B, right? So they are really what they are doing specifically is preventing ovulation. People think really they act by causing sort of a spontaneous abortion or an induced abortion of an early embryo. Typically, it's just giving a surge of progestin, which is the common analog, and it's preventing that ovulation if it hasn't already happened. So we're going to talk more about that. Abstinence is another way, right? So this completely, male condom, coitus interruptus, abstinence, they're basically stopping the sperm deposition in the vagina. That makes sense, right? And then there's tubal ligation. That means the tubes are tied, ligated, cut, so there's no longer a discrete fallopian tube. There's a gap, right? So the egg cannot be picked up by the oviduct or by the fallopian tube. So there's a lot of different mechanisms, and they act at various steps in these pathways of gamete development, transport, fertilization, transport of the embryo. All right, so the most common ones I'm going to emphasize, these are the ones used in the US, OCPs, and a lot of us in the field will just call them OCPs, but you guys will probably see birth control pills, right? These are oral contraceptive pills. They have hormones in them. Tubal ligation, getting the tubes tied, male condom, and vasectomy. Take a guess at what vasectomy is. And many of you on the lecture exam actually massacred this word. Like I had to really figure out half credit. I had like vans affrons. I had all kinds of like French sounding words.
Wait,
You're like, I can't, you were one of them. I can't.
Tour de France?
You were one of them too.
Yeah, I was Tour de France.
Vase. Okay, so what's it transports sperm from the epididymis where they're matured and stored through over the bladder, in through the ejaculatory duct, into the urethra. What is that big giant duct where they're stored and transported? Vas. Vas deferens.
But it's fun to say Tour de France.
And you sort of spelled it that way, so yeah. All right, vas deferens, that means the vas deferens leading from the epididymis up is cut, ligated, and separated, just like the tubal ligation. Okay, so vasectomy, you were bisecting or resecting the vas deferens. And I'm going to show you what that looks like. I have to give a little warning. There's a trigger warning. This lecture has some graphic images, okay? There are some slightly, hello guys, there are some slightly graphic or stirring images in some of these, it's kind of unavoidable for some of these things to show the biological situations and what is happening. So, Mom.
Why is how is a vasectomy reversible but tubal ligation?
Tubal ligation, very hard. They cut the entire tubal ducts, the fallopian tubes, and they're totally separated. Hard to undo that. Hard to open those up. There's a lot of scar tissue and closure that happens. Vasectomy, a lot of times what they can do is cut further down and then reattach. That tube is very long, and so they can reattach so there's still a lumen and there's still a transport duct. So it's a little easier to do. But with that being said, I will say male vasectomy, even though it's a little more reversible than tubal ligation, the male's body often develops antibodies against their own sperm. Remember, they're genetically distinct from themselves. So sperm have now been exposed in the intra-abdominal cavity, at the opening. They're still making sperm. They're just not able to be transported up and out. The antibodies attacking sperm becomes a real problem. So they attack their own sperm. So they end up having fertility problems even after a vasectomy reversible. So I should mention, these two things are pretty much irreversible. These are a permanent sort of situation, so the individual has to be very sure that they don't want to have children or they have enough children. Their family building is done, okay? So the rhythm method, and I will say this one's pretty much outdated. Some people still do this, and it's still discussed, and it's a factor in contraception. It requires tracking the female cycle and ovulation times. This can be used for sort of trying to prevent pregnancy and trying to predict fertility. Like, when is the best time to achieve a pregnancy if you're going to keep track of the cycles? These are rough estimates based on several different studies that have looked at these different contraceptive methods, 96 to 95% effective. Can time ovulation by tracking the female's temperature. Also, you can test for the LH surge. So there are ovulation tests. We'll look at these in lab. We're not going to do them. I'll give them out, though, if you guys want to try them on yourselves at some point. It's kind of fun. But it looks for that LH surge, that increase in the rise of LH hormone, and it says pretty much within that 24-hour window, that's when the woman is ovulating. Pretty good indicators for ovulation, but of course they're not a guarantee. These are not a guarantee. I wouldn't rely on this to say yay or nay, either way. Pregnancy is typically unlikely as long as this couple has sex more than 6 or 7 days before ovulation and more than 24 hours after ovulation. Remember, that is sort of the main fertility window. Sperm can live for a long time. That's why we say 6 days before ovulation or more. Previous numbers were like 2 or 3 days, but we know they can live longer than that. So if they're in there waiting, hanging out, egg gets ovulated, boom, you can have a fertilization event. And the egg, as Sharon mentioned, and as I've talked about, it only lasts for about 12 to 24 hours. That egg has to be fertilized. If it's not, it degenerates, gets resorbed, it's gone. In the olden days, this is like in the 70s and 80s, I don't know if you guys have ever seen these, or these cycle beads. They're still around. You can get these versions of these little cycle beads, and you basically move the little indicator so you can track exactly where your follicular phase is, where your ovulation event likely is, where your luteal phase, and where your menses is. And keep track of sort of how many days your cycle is. Again, this is an estimation. This is not clinical. This is not exact. There's a lot of tracking apps, and Dr. Sharon brought up some of these different tracking apps where you can track your sort of cycle. There's Ava, Kindara, Natural Cycles, Clue, Tia, a lot of these tracking apps, where that you can even input things like basal body temperature. You can put all the information in. So it'll track it for you, more than just when your period is and then how long your cycle is. It'll track some of these other things. Yeah, Drew.
So when you're ovulating, is that like the week before your period, or I'm confused. I don't know.
Nope, you guys have to review the menstrual cycle. I'm not going to go over all that over again. Menstrual cycle is day 1 to day 28. When you ovulate? 14. When is menses? 1 through 5, give or take, right? So menses is 1 through 5. You go another 9 days, typically you hit ovulation. But remember, some women have a shorter follicular phase. Some can ovulate at day 10, 11, 12, 13. So it varies. Yeah, Alex.
Isn't there also like pregnancy tests, but they're not pregnancy tests, they're for LH surgery?
Yes, that's what we're going to look at in lab. They're ovulation tests. They detect LH almost like GnRH, but they're detecting LH when your LH level surges. We also, we talked about P-Tracker before. This is less. You can now put in, you can upgrade and put in all these other things, but mostly it's to track your cycle length and when your menses actually happens. Basal body temperature, typically it's around here, right, 36 something, right? This is Celsius, not Fahrenheit. Stay here. Right around ovulation, there's a tiny little dip, and then body temperature goes up a little more than like half a degree or so, and then it's higher from that point forward. So you can see that temperature, basal body temperature, can give you an indication of when LH surge is happening, when ovulation is happening, if you track this. And women that are trying to get pregnant and are having problems, sometimes for 3 months, 6 months, a year, they will start tracking these before they just automatically pursue IVF. It's very expensive. Dr. Sharon didn't talk about the numbers, but IVF can be $8,000 to $12,000 just to do in vitro fertilization in the dish and then do insemination. And a lot of insurances don't even cover that. It's very, very expensive. So a lot of women will try to do this. Let's track the temperature, let's do the LH test so I can do the ovulation test, and we can try to see when the best time is. Oral contraceptive pills, many college students, female college students will use this. This is one of the preferred sort of types of contraceptives. They can be 91 to 99% effective. So notice there's variance in all of these. And a lot of this variance has to do with the individual woman and compliance. What is compliance?
Like your ability to take it at the same time.
Consistency.
Are you taking it? Are you following the instructions? Are you consistent? Are you not messing up? Remember in our pregnancy panel discussion, I said some things that I did. I would forget. I would just forget to take these. This was not an effective method for me. I was too busy and too all over the place to remember every single day at the same exact time. So I was not compliant. And I was, in this case, it was 0% effective for me because I got pregnant on birth control pills and then didn't know I was pregnant because I continued taking the pills, which is also not good because you're giving the developing embryo and developing placenta a bunch of these exogenous hormones, okay? And they ask you that, are you on birth control pills? Yes, okay, stop those immediately. Combination, usually estradiol and progestin or just progesterone or progestin. They have a negative feedback inhibition on GnRH, so there's no ovulation. So now this is where I spent so much time on the female menstrual cycle, hormones coming from the brain, puberty, and reproductive axis. What is involved? Because to understand how a lot of these work, you have to understand that biology. GnRH, if you have negative feedback by E or P, remember those at a certain level, an intermediate to low level, they exert negative feedback inhibition on the hypothalamus and the anterior pituitary. And if they're negatively inhibiting, what does that lead to? What happens?
No LH.
LH, FSH, what? Is low, is not released. Not released. You don't get that big fat surge of either one. It keeps those very low, okay? So preventing ovulation because you prevented the LH surge by having these sort of phasic levels of hormones negatively inhibiting the brain and the anterior pituitary. So they act like a prolonged luteal phase. Luteal phase, you have progesterone levels up, you have estrogen levels at sort of a moderate level. They act like that. And these hormones have the same effects that the hormones in the body, that the ovaries, the follicles are releasing, the corpus luteum are releasing. They're just like those. Okay, they're just like those. They're exerting these effects on the brain. Typically, women have lighter regular periods. It also thickens the cervical mucus. Okay, I didn't mention this before, but in the menstrual cycle, and when we're looking at the uterine components of that cycle, progesterone actually causes a thickening of cervical mucus. So in your cycle, when you have that surge of estrogen and that surge of LH, so that positive feedback response, you actually have a thinner, more penetrable type of cervical mucus. That allows sperm penetration if and when there's sperm in the female reproductive tract at the time of ovulation. After that, luteal phase, the cervical mucus thickens. And many women will know this. They get little cervical mucus changes with discharge and spotting and different characteristics that you can see, you can detect throughout the cycle. So this actually thickens that mucus, somewhat what happens in the luteal phase. So it's not as penetrable or hospitable for sperm. Thins the endometrium, so the endometrium still proliferates, but it's thinner than it normally is. Okay, so that's why the periods are often lighter and shorter, because you're getting endometrial proliferation in that proliferative phase, but it's thinner. It's a little scrawnier. Placebo pills, which are sugar, those are taken for about a week in most of these OCP setups, and that allows menstruation. Basically, placebo pills are taking away the E and the P, like when the corpus luteum dies, degenerates, no more E and P, uterus has no more response to those hormones, gets shed and gets sloughed. When you take the sugar pills, you're removing the E and P, just like at the end of the luteal phase, and then boom, you get a menses. Newer pills, though, reduce risk for endometrial and ovarian cancers and then reducing osteoporosis. So they used to have high doses of some of these hormones, too high. And then sort of targeting it and doing a lot of dosing studies, a lot of clinical studies, and looking at a lot of women, they've got these levels now where they're much lower risk for some of these reproductive cancers, which used to be higher associated with OCPs, especially when they first were getting really predominant, like in the 80s and 90s. Now it's better. And they actually can serve to reduce osteoporosis risk because you're getting a low dose of estrogen or estradiol. Okay, OCPs, I'll just talk about the risks and I'll take your questions. Risks: nausea, weight gain, tender breasts, mood changes. Sometimes there's less acne, or if there's acne issues, that tends to subside on certain regimens of OCPs because they're giving more of a steady level of these hormones instead of up and down. But some of these other things do happen. Rarer risks are blood clots, stroke, heart disease, and hypertension. And if you have a familial risk factor for any of these in your immediate or extended family, oftentimes the healthcare provider will take that into consideration of using the OCPs or which type of OCP to actually use, or to use another method altogether. Because they do affect that, because you're getting exogenous estradiol and progestin in most of these. Even greater risk with smoking, and they will ask you guys probably gonna ask, do you smoke? Right, they're not just curious about your overall health. Smoking is a contraindication to taking hormonal therapies or hormonal contraceptive pills. So also birth control, there's a patch, stick right on the skin. You can put it somewhere on the skin that's not visible. Birth control shot, there was one, Depo-Provera, there's a bunch of different types. Some of these have problems with bone density measurements, 2 years of shots. And these women actually, some of them don't ovulate for a year after the shot. So they're pretty potent and it might have effects on bone mineral density. So not many people are doing these as much. And they've changed these and sort of changed the doses, but those are still risks. These are reversible, can do with breastfeeding. So you can take OCPs, you can stop, and you'll resume fertility. And you can breastfeed, you can nurse. So that's why a lot of women like them for those reasons as well. We also have the new extended cycle ones, right? We have, these are about the same, 90s to 99% effective. They're basically 3 months or 1 year sort of setups where you can do, there's one that's like seasonique. There's a whole bunch of different brands and name brands and ones on the clinical market. But basically these occur in like a season or a set of 3 months or a full year, okay? And so there's minimal or less bleeding. So there's less periods per year. Many women actually like this, right? And I should have prefaced all this by saying, there's no one right contraception or exact type that fits the bill for every female, right? A lot of this comes down to you, what you want, what you don't want, your personal preference, your habits, your lifestyle. All those different things have to be considered. So it's not like a one size fits all. There's going to be pros and cons with every single one of them. Yeah, Alex?
So is it like for these, do you take the hormone pills for like 3 months or a year and then you have
Yep. It's like the 28-day cycle, but you don't have any placebo sugar pills in there. So you just keep going. And ever, if you want to change it, all you have to do is not take the pill for 5 or 7 days, and boom, you'll get a menses. Or take a sugar pill. You don't have to do a sugar pill. Sugar pills are just to keep you on the rhythm of taking the pills. Because you could literally skip that whole different color the whole time. It doesn't do anything. They're just sugar. It's a placebo. But it's to keep you in the rhythm of doing it. So there's decreased cramps and acne with many of these more seasonal or year-long extended cycle ones. However, it's harder to know if you're pregnant, right? So some of these, you don't have a menses for many months to a year. If the woman does get pregnant, oftentimes it's really hard to know because she wouldn't be bleeding or spotting or having any period or any signs of that anyways. So the awareness is sort of not there. The risks of these, again, changes in period, sometimes nausea, tender breasts, headaches, similar to regular oral contraceptive pills. The more rare risks are high blood pressure, again, blood clots, strokes, heart attack, especially if there's a familial history. So in generally, this risk is very low, but if there's a family history, the risk goes up. Question, Lauren?
Okay, this might be a dumb question, but for the first type of OCPs, like how does menses occur without that LH surge? Like aren't they dependent on one another? Like
No.
I've always wondered that.
No.
Like how does that happen if
No.
there's no ovulation?
So high levels of estrogen coming from the follicles, the larger follicles, right, especially the dominant follicle, causes a positive feedback on the brain that causes the release of LH, that causes the egg to rupture, be picked up, right? What's happening in the ovary is different than what's happening in the uterus.
Okay.
You don't need ovulation to build up the endometrial lining, and that's what these are doing, right?
Mhm.
They're at a level that causes negative feedback and prevents ovulation and LH, but they're at a level that also allows a little bit of proliferation of the endometrium and a
Okay.
sloughing of the endometrium. So they're taking those two things out of synchrony.
Okay.
Does that make sense?
Yes.
We're just playing with the hormones. We're playing with the hormones based on everything we've learned about the menstrual cycle.
And does the weight gain in OCPs, like, does it just increase hunger, or does it affect like leptin and that's what increases?
It's not really clear exactly how it does it, and it doesn't happen to every woman. Some women actually lose weight. Some women gain a little bit of weight. So they're having a level of estrogen and progestin, and sometimes it affects their eating and their storage of body fat. It just, yeah, Tatiana?
What kind of OCP would it be considered if there's like 2 sugar pills instead of a full week?
I don't know. It would just be a very short menstrual phase, oral contraceptive pill. And I mean, you could do that on your own, you could do that. It's not recommended. You want to keep it in synchrony, and that's why they color code it and make it all easy to follow, because like me, you'll fall off the compliance wagon and then women will get pregnant. We don't want to do that. You think it's easy to follow these things, but really it's not so easy. Doctors deal with this all the time, and nurses, about cardiovascular health and about taking contraceptives the right way and taking medications the right way. Compliance or non-compliance is one of the biggest issues in the medical field, and why heart disease is the #1 killer in the United States, because you can get all this information, all these instructions, and they don't get followed, right? And then it leads to all kinds of things. So following the drugs, the protocols, the medications is absolutely critical. So we try not to tweak with all that stuff very much and keep it sort of a set. This is just the cycle we're going to follow. Intrauterine devices, and I actually have this. This might be TMI, but I can't do the oral contraceptive pills. I've ruled that out. Doing the patch and the shot and the implant and all these other things, I was like, eh. And I've had students that have done this. Some students have loved it, worked like a charm. Other students are like, nope, hated it. I was too irregular, I bled, I spotted all the time. For me, it worked like a charm. So I really liked it a lot. 99% plus effective. Very, very effective. Especially now, I already have 3 kids. I've already built my family, I have it. I don't really, in my 40s or 50s, want to have a baby. My mom entered menopause late, so I still am sort of probably the end of my fertility window. So this is a good choice for me. It's very effective. It's a T-shaped device placed in the uterus, has progestin or copper, so a little copper wire wound around it, or a little contained cylinder that has progestin in it. The Mirena is the common one. I have the Mirena. There's lots of different types. And this is the uterus, showing the fundus and the body of the uterus. It's inserted by dilating, just opening up the cervix a tiny bit with a speculum, so it goes, and then insertion right into place, making sure the arms are kind of funneled to the top of the fundus. This is the fundus, this is the body of the uterus, and it kind of just sits right in that location. It has 2 little tiny thin, almost like fishing line kind of wires that kind of just hang down into the top or superior end of the vagina, so they kind of hang right into there. Lasts up to 5 or 10 years. You can have it removed at any point, but it has longevity. It's usually not going to slip or come out or be faulty. They put it in the right way. It lasts for a long time. Prevents sperm from reaching or fertilizing the egg. Also can prevent the embryo from implanting if there is an early fertilized embryo. So typically it prevents the sperm from even being able to reach. Sperm don't respond well to copper, the metal, copper, and they don't respond well to high levels of progestin or levels of progestin that are at a higher level than they're used to. So typically it even prevents sperm from reaching past the IUD and getting into the fallopian tubes. Sorry, it's very effective. It's reversible. So for some of these things, I mentioned reversibility or not, because that's important, right? You're thinking, can I do this for a little bit and take it out and I'm fine? Because you don't want to have fertility issues subsequently if that is in your plan. And you can use this with breastfeeding. So it's benign, it doesn't affect breast milk, it doesn't have any negative effects on a nursing baby. What are the risks? The risks are cramps. Some women experience cramps and pain, especially more initially in the beginning, irregular periods and spotting. Sometimes there's ovarian cysts that develop, especially the progestin once releasing low levels of progestin. Rarer risks are slippage of the IUD, so it actually starts to slip and fall out, or it tilts and gets wedged in the wrong sort of dimension. Pelvic inflammatory disease, or PID, sort of a flare up and sort of scarring and affecting the inside of the endometrium, or PID. Infection and different things. Those are mostly rare. For most women, I will say, the majority in the studies where they've tested and looked at this, women experience just a little bit of sort of spotting or bleeding in the beginning, the first 3 to 6 months, and then after that, it kind of goes away. And they get very, very little spotting, so it's almost like no period, or light spotting periods that are kind of at regular intervals. Yeah, Michael?
Is it possible that like your body just rejects it because it is like a foreign object?
Not usually, not usually. There's no rejection, it's too big of an object and it's benign. So there's nothing in it that usually will cause a reaction or an immune reaction. Or the thing is, it's kind of big, and so there's issues with slippage occasionally. Or if a woman has a uterus that's sort of antiverted the other way, instead of being in the anti-flex direction, it's kind of in the retroflex direction. My sister had that. She had an IUD put in, and it was not in the right position, and it was uncomfortable, and it's crampy, and they went in, they actually did an ultrasound, and they could see that it was like tilted back and wedged the wrong way. So based on the anatomy of the body, sometimes it's not a perfect fit. But the woman's body does not go, ooh, this is foreign, reject it. It doesn't do that at all, for the most part. Yeah, Drew.
Another fun fact is that the copper IUD can be used as an emergency contraceptive, so like within like 5 or 7 days after unprotected sex, you can get a copper IUD and it's like an emergency contraceptive.
That's true. Thanks for sharing. That's true. Yeah.
Can you
Lex.
like feel it instead of you?
Okay, so we're getting into the weird stuff now. Yeah, you can feel it. And actually, you're recommended, so you have to feel it every once in a while. You have to feel the little fishing line. Can I feel the little fishing line? Oh yeah, there it is. Okay. It's a little challenging to do, but it's recommended to actually make sure that it's in place and you can feel the little line hanging into the uppermost portion of the vagina. It doesn't hang all the way out your body. It's up inside the vaginal canal.
How big is it? Like,
They're pretty long. They're a couple inches long. They're, like on this, they're as long as the IUD itself. So it goes through the cervix and out into the top of the vagina. So you can sort of feel it. Usually they're off to the side, but you can feel it. I know it gets weird, but it's a self-check. Like, okay, I'm good. Yep, it's all good there. Okay, this is what an X-ray showing an IUD. So the uterus would be all right here, ovaries here. This is an IUD. In this situation, it looks like it's tilted a little bit. This woman's uterus just happens to be tilted a little bit. So the IUD is just right there going into the fundus of the uterus, body of the uterus, tilted off a little bit to the right. Here's how it's positioned in the uterus. Here's the strings. They feel like fishing line. They're kind of that polymer, the same consistency. They hang down just a little bit, like an inch past the neck of the cervix, opening of the cervix into the vagina. I know this always blows people away. And this used to be like, oh my God, I never would do that. That's creepy. Like, I don't want a foreign object in my vagina, in my uterus and hanging down in my vagina. But then as I got older, I went, you know what? I suck at oral contraceptive pills. I don't want to do all these injectables and implants in my arm and stuff. So I thought, might as well just give this a try. It has worked really well for me and a lot of other people I know anecdotally, including students that I've talked to. Although I've had 1 or 2 students that really didn't like it and they bled more and they had cramps. Yeah.
Does it hurt to get it removed?
I've never been through that, but yeah, people report a little bit of pain. Actually inserting it, a little bit of pain. Yes, a little bit of pain. Right. It's a little bit of pain, a little bit of pressure, because they use a little speculum to open the cervical neck. Your cervix is tight closed, right? It's got a neck, it's got tissue, it's closed. They open it up a little bit and insert it, position it right inside there. There's a little bit of pain and discomfort. So putting it in and taking it out, yes. But honestly, it's like 30 seconds.
it feels like
You're familiar, I can see. You're like, yep.
Yeah, it feels like menstrual cramps.
Right.
And then you like cramp for like a couple hours afterwards. But like the IUD specifically, you can't feel like I don't like walk around and can like feel it in there.
Right.
But like it's
Right.
meant for like the 7 years that I won't have cramps, like that little bit of like hour and a half, I was like.
That's a
okay,
good way
I'll
to
do
put
that.
it. That's why I was like 30 seconds, 60 seconds. Yeah, I can handle that. And no periods. And like all the so for each of these, this is a great point, Simone, that each of these you have to weigh out like the pros and cons for you. That is your individual choice. What do I see as the pros? What do I see as the cons? Some of you might be like, hell no, never. I can see it all over your faces. That's totally fine. I'm not a proponent of any one specific type for every type of woman. It's gonna vary for the individual, okay? Contraceptive implant, 99% plus effective. Did you guys wanna make a comment about IUD? I just don't wanna spend forever on contraception because we gotta get to abortion as well. IUD? We've talked about IUD.
Yeah, I was just gonna say I have an IUD and I absolutely hate it, and like I'm waiting for the day to get it out. So like when I got it in, yeah, it hurt. I have cramps.
Right.
But like my period, it feels like it never stops. Like I'm constantly been on my period.
Okay, so she, and we've talked about this.
Yeah.
I wasn't gonna bring it up unless you brought it up.
Yeah.
But we've talked about this. She is in the more rare category where it actually causes the cramps and more bleeding, and your body just doesn't get into that nice rhythm of lack of period. So you can have contrasting responses in different women's bodies with the same exact device. Okay, so this indicates there's a lot of variability among women. 99% effective is the implant. So these are a rod of progestin that's implanted on the skin under the arm, so the underside of the arm. An example is Norplant. I've had students that have done this one before. That some liked it, some hated it, had infection, had problems, had scar tissue. Lasts up to 3 years, very effective, it's reversible, fewer and lighter or no periods. What are the risks? Scarring, headache, pain, infection in the arm, tender breast, weight gain. Some of these are similar to OCPs and have effects like that. The rare risks are slippage of the implant, ectopic pregnancies are slightly increased with an implant, ovarian cysts, and serious blood clots. These are the more rare risks. I don't know why that is exactly. It's the hormone progestin in the circulation under the arm. There tends to be an association with some of those risk factors. Those are very rare, but they are. So notice any of these, even if in a study of 1,000 women, if 5 experience something, it has to be documented. So even if it's very, very rare, we have to, the FDA and CDC and all that, it has to be documented somewhere in the studies and on the label. Yeah, Jackie?
Yeah, my best friend got it in her arm, and when she went to like get it removed, it was like all the way over here.
They slip. Yeah, I had a student that didn't slip, but it caused massive scar tissue, swelling, infection. It was painful, and she was like weight training. She was a powerful, buff like girl. She trained me for a little while. She was like, come to my thing and I'll do some fitness training with you. And she had it, and she was like, I gotta get it out. It was not effective for her at all. She was always using her muscles and very active. So she had it removed. And then subsequently did an IUD. So it just depends. Sometimes you have to try more than one type to see what really works for you. Plan B, or Plan B one step, this is one of the over-the-counter ones that you can buy. It's a high-dose levonorgestrel. Levonorgestrel is progestin. It's a type or a name, the sort of drug name for it, or the, what's the word I'm looking for, commercial name for it. 1.5 milligrams, which we didn't really talk about values in units because that's just overwhelming for a lot of these hormones. I just want you to know the hormones and what they do. This is high. This is a huge blast of progestin. So if you take it up to 3 days after unprotected sex, it has an increased efficacy, okay? No prescription if you're over 17 years old. There's issues in different states, this varies. I can't summarize it all, but in general, you can buy it over the counter, but also you have to get it from like behind the counter. You have to have a person give it to you. They lock these up, they're more expensive. You can't just grab them off the shelf in most places, right? You have to, with some of the more expensive products and things, you have to have somebody get it for you, which is also kind of an issue, right? It could be embarrassing, that's a factor that comes in. But kids are not able to just grab those. Prevents ovulation, may also prevent fertilization because it affects cervical mucus. You're getting a blast of progestin, so it helps make the cervix mucus less penetrable. Also may prevent implantation if there is an early embryo. But the main way it's thought to act is by preventing ovulation. So Plan B is most effective if taken within the first 24 hours to 72 hours after unprotected sex. And it's if you haven't ovulated yet. A lot of times if you've already ovulated, and there's already an